Good morning, everyone. I'm Madeline Robinson from the Neurological Foundation. Welcome to Brain Day Wellington. Fabulous to see you all here. This is part of the 2013 Brain Awareness Week in New Zealand, and it's proudly sponsored by the Neurological Foundation. Now, we've got one or two housekeeping things like turning off all mobiles, please. Checking your exits in case there was an emergency, so you know where to go. And letting you know that the bathroom facilities, you come out of the lecture theatre here and go straight down the hall and you're on the left towards the end of the hall. And today, when you register for the day, you go into a competition to win one of three fabulous books called The Power of Us. And I don't know, has anyone put your hand up if you have already seen this in the bookstores? Beautiful, beautiful book, isn't it? And it features some fabulous people. So if you wouldn't mind registering, filling out that little form, then it helps us say, you know, we've had so many people from Cavity Coast come and so many people from Central Wellington, and it helps us justify putting on a day like this. Thank you again for coming. Last year, the Neurological Foundation celebrated 40 years of funding neurological research in New Zealand. In 1972, not long after the formation of the foundation, 5 neurological research projects were approved at a cost of $28,200. In 2012, the foundation reached an astonishing annual contribution of $2 million in funding. So we're thrilled to have over 50 funded projects currently across New Zealand. Through this funding, the foundation continues to make an impact on the progress of research into devastating disorders such as Alzheimer's, Parkinson's, Huntington's disease, stroke, epilepsy, migraine, brain tumour, motor neuron disease, and many, many, many more. And these will affect 1 in 5 New Zealanders during their lifetime. And it's only through the generosity of the Foundation's supporters and bequesters that this achievement of $2 million in funding has been possible. Today's event is supported by Victoria University of Wellington. Together, we're thrilled to present an insightful lineup of lectures and seminars that we're sure will leave you inspired and with a greater understanding of the incredible research being carried out in laboratories and clinics in this country. So our first guest speaker today's exciting lineup is Professor Paul Glue. And his lecture is Fast and Slow Drug Treatments for Mood Disorders. Professor Paul Glue is a psychiatrist and head of psychological medicine at the Dunedin School of Medicine. His research focuses on clinical and basic psychopharmacological pharmacology, and in particular in the areas of mood and anxiety disorders. Special areas of interest include the pharmacology of drug treatments in psychiatry and the investigation of disease processes in neurological and psychiatric disorders. Professor Glue is also interested in technical aspects of clinical trial design, including modelling and simulation. He has published extensively with more than 300 published papers, book chapters and abstracts. In this lecture, Professor Glue will also discuss the potential of new treatments for anxiety and depression. So please give a warm welcome to Professor Glue.
Thank you all for coming. I very much appreciate seeing so many people out on a Saturday morning. I think if this were in if I were in Dunedin, I'd probably be lying in bed listening to Kim Hill. So I do realise that this is a real privilege having you here. Would you mind popping the slides on? Okay, cool. Ah, fantastic, the slides. So again, I appreciate the invitation from the Neurological Foundation, and I also appreciate Wellington for turning on such beautiful weather. I realise it's an imposition that you can't water your tomatoes or your lawn, but it's worth it just to have this fantastic weather. So again, a little bit about me. I am a Kiwi. I was born in Christchurch. I did my medical training in Otago, and then went across to the UK for psychiatry training, and then did an MD in psychopharmacology. And really most of my career until about 2008 was working in the UK and US doing clinical pharmacology research in both academia and big pharma. And then came back to Otago 4.5 years ago. I do sit on a number of scientific advisory boards, and currently I'm being funded to look at a drug dependence treatment by Demerix. None of these are related to what I'm going to talk about today, so I don't think there's a risk of commercial bias in what I'm going to mention. So what I'm going to do today is talk about a couple of things, the concept of fast versus slow treatments, to look at what we've got in anxiety, and I think the concept of fast and slow is well established there. But then to look at depression, and to try and tease this together to look at, do we have, based on the way that treatments are working, is there a common mechanism of action for different types of treatment for depression? So the concept of fast and slow treatments, fast drugs work fast. They work in hours or perhaps a day or two. And an example might be giving a hypnotic, an antihistamine for sleep, giving a benzodiazepine for anxiety. You don't want a hypnotic to take several weeks to kick in. You want to take it and then be asleep in an hour or so. And generally the way that these things are working is they're binding to fast-acting transmitter systems, typically those that involve amino acids binding to ion channels. And you've got a direct linking between the drug that you're giving and the system that is involved with signaling. Slow-acting drugs take weeks or sometimes months to work. And typically what they're doing is acting indirectly. And often the kinds of things are interacting with, say, peptide transmitters or modulatory systems such as norepinephrine or serotonin. And to get a sense of how this might look in anxiety disorders, the vertical bars here are the different anxiety disorders as diagnosed by the DSM, the American classification system. And then on the horizontal bars are the different treatments we have for them. And they're also subdivided into slow drugs and fast-acting drugs. So antidepressants work broadly across all different types of anxiety disorders. But typically, when one takes them, they take perhaps 2 or 3 months before the benefit is evident. We've got slow-acting drugs such as buspirone that only seem to work in generalized anxiety disorder. We have a whole bunch of fast-acting drugs, benzos that work fairly broadly across anxiety disorders, antihistamines and antipsychotic drugs that at very low doses seem to be mainly antihistaminic, antiadrenergic drugs like clonidine, and then the alpha-2 deltas that I guess are known as epilepsy or pain drugs, but also work pretty well in generalized anxiety. And to give a sense of how the slow and fast component works, might appear clinically, what I'm going to show here is the time course of activity for an antidepressant such as an SSRI or a benzo in panic disorder. And the higher up you are on this anxiety score, the worse your anxiety is. So typically an antidepressant can often worsen anxiety if it's used at high doses initially. You get a gradual onset of effect over, say, 6 to 8 weeks. And after you've treated someone for, say, 6 months, and you stop the antidepressant, the anxiety disorder is, there's a less than 10% chance it will recur. Benzos work straight away. Within an hour or two of giving someone with panic disorder a benzo, their panic attacks stop. However, there were some trials in the 1980s with alprazolam that treated people for 6 months or longer, kept their panic attacks away, but when the benzo was stopped, almost all of them, over 90%, got their panic symptoms back again. So clearly you're suppressing the symptoms, but there's no sort of curative element. And the overall effect size, the difference between active treatment and placebo is about the same for both treatments. So in clinical practice, the way to use the slow and the fast-acting drugs is to use a fast-acting drug as an induction treatment. So someone comes along with severe anxiety, I don't have any problems using a short course of benzos to get immediate control over the anxiety symptom, realizing it's just going to be a short declining course of treatment. And at the same time, to put someone on a long-acting treatment, such as an SSRI or another antidepressant, and keep them on for 6 months or longer with the expectation that when we stop it, that there's a very low chance that their anxiety symptoms or anxiety disorder will come back. So for anxiety, it's actually very easy to treat pharmacologically. I know that I'm avoiding any mention of psychological treatments. In terms of my clinical practice, I'm very pragmatic. If people need psychological treatments, I'm happy to include them in it. But the focus today is on medications. So looking at that fast versus slow paradigm, what options do we have for depression? And I'm going to talk about depression as if it's a monolithic, single disorder. It's definitely much more complicated than that, and in 10 or 15 years, I suspect we will be able to reliably diagnose different types of depressions. And the way it may look like is, perhaps based on the diagnosis, bipolar versus non-bipolar depression, clinical symptoms, so atypical depression where you get increased sleep, increased appetite, seems to respond preferentially to monoamine oxidase inhibitors. Looking at biochemistry, that certainly states which have increased inflammatory markers appear to be a different subtype of depression. And an example of this is giving interferons to people with hepatitis C. One of the most common side effects is developing major depression. About 30% of people will get it. And the other thing is just inference, that anytime we use a treatment, about a third of patients will get better, a third will have some kind of response, and a third show no response at all. So, and this sort of falls into the much more sort of generic sense of there's heterogeneity in treatment response. We must be dealing with a number of different disorders. So most of the work I'm going to talk about today is in patients who have DSM major depression. So right now, in terms of treatments that MedSafe has approved for depressive disorders, we have a range of different drug treatments, antidepressants, mood stabilizers such as lithium or some of the antiepileptics, and antipsychotics for bipolar depression. We also have ECT, which seems to work a little bit faster than antidepressants, but it's certainly not, it certainly takes a couple of weeks for the effects to kick in. And just to give a sense of how quickly antidepressants do work, this is a graph taken from the first stage of the STAR-D study. This was looking at stages of treatment in major depression and what you do if the first treatment isn't working. This is from the first stage where about 4,000 people were given citalopram for 13 weeks and is looking at people who got better. These are the red vertical bars, or people who showed a 50% reduction in symptoms, so-called treatment responders, which is the purple bars. And on average, the people who got better or responded did so at about 6 weeks. But you can also see there's a lot of heterogeneity in that as well. Some people respond a little bit faster. Some people take up to 3 months or slightly longer to show improvement. In trying to look at rate of response to ECT or anti-epileptic mood stabilizers, in this case carbamazepine, you may know it better as Tegretol, we have to go back to a pretty ancient study from the US National Institutes of Health. And in the study, they had patients in hospital and they did mood ratings daily out to about 4 weeks. And in the group of patients who got ECT, you get about a halving in depression ratings over the space of 2 to 3 weeks. So again, we're looking at an average result, but typically you're seeing about half the time taken to get an improvement compared with, say, antidepressants. Carbamazepine, again, it's about a 4-week duration to get perhaps a 40% reduction in mood symptoms. So carbamazepine in this situation would look like one of the slow antidepressant-like responses. What other things could we look at that might be also produce antidepressant effects but haven't yet been approved by MedSafe? We have a bunch of treatments that seem to work incredibly quickly. Sleep deprivation, deep brain stimulation, ketamine. There are some other drugs, mifepristone, this is RU486, the pill that's used for termination of pregnancy, scopolamine, an anticholinergic, and different immune blocking treatments. I'm going to focus on the fast-acting treatments today, but just to give you a sense that there's actually quite a wealth of research looking at different mechanisms that's going on at the moment. So sleep deprivation. When I was a registrar in the early 1980s, it was a technique that was very, very topical at that stage. And sleep deprivation is basically what it sounds like. You have patients who are depressed, you bring them into hospital and you keep them awake. And it typically means you have to have a nurse sitting with them because patients, for whatever reason, will want to go to sleep. Surprising, isn't it? And in this older NIH study, one of the other treatment arms was bringing people into to the clinical ward and sitting with them overnight and making sure they didn't sleep. And you can see within 24 hours, you're getting a 40%, on an average, 40% reduction in depression ratings. Sleep deprivation does work. So, why don't we do sleep deprivation for all of our depressed patients? The answer is that people get their depression back pretty quickly afterwards. You can see that within 4 or 5 days, the depression ratings are pretty much back to normal. It only works in about half of patients. So half of your patients will be tired, grumpy, and still depressed the next morning. Very, very unappetizing. As I mentioned before, the responses are not durable. And you know, I think the sleep literature suggests that if you try and keep people awake for more than, say, 4 or 5 days, the risk of paranoia, psychotic symptoms are certainly there. And the logistics are very difficult. Patients hate being kept awake. Nurses hate having to nag patients not to sleep. So it's I wouldn't say that we've found the new cure for depression, but I think the important thing is mechanistically, and I'll show you some of the brain biochemistry data or serum biochemistry data associated with sleep deprivation later on in the talk. The next thing is to look at deep brain stimulation. So this is putting wires into people's head and stimulating bits of brain tissue. And firstly, I'd like to get you up to speed in terms of what's happening to brain blood flow or cellular metabolism in major depression. And this is a brain image from a meta-analysis of blood flow studies in major depression. And the first thing to notice is that, firstly, most of the blood flow changes are associated with frontal cortex or prefrontal cortex. The second is it's not that blood flow is always decreased or always increased. You've got a mixture. So some areas do seem to have increased activation. Some areas seem to have reduced activation. And this is represented by the blue and red areas. And again, they're all highly relevant areas in terms of emotional generation or emotional modulation. And Helen Mayberg, who's a psychiatrist from Toronto, and her specialty is in treating extremely severe refractory depression, noticed that in people who did have severe depression, that this area, the subgenual cingulate, these are the purple arrows showing the image in the brain sections, is metabolically overactive in treatment-resistant depression. So what she's showing in the MRI scans down the bottom here are the areas where there's increased activity, increased blood flow in patients with refractory depression compared with controls. And in functional terms, Brodmann's area 25, or the anterior cingulate, is associated with generation of emotional states. And I guess the inference there is that increased activity is generating a depression signal. People are picking up as low mood. And again, from other studies, having increased blood flow or increased activity in this area predicts non-response to drugs, to psychotherapy. And so she and a neurosurgeon put wires into people's skull and then turned them on. And the results were quite extraordinary. And what I've done is lifted some direct quotes from her paper in Neuron. And typically, as the stimulator was switched on, people reported an improvement in mood instantaneously. A sudden disappearance of something negative, a sudden sense of intense calm and relief, a disappearance of a void. And when the stimulator is switched off, the depression comes back again. So what we're looking at here are some blood flow pictures from an MRI comparing activity in Brodmann's area 25. This is marked with the pink arrow. Comparing blood flow at 3 months after stimulation with the baseline in the 20 or so patients with depression. And you can see that the stimulation has switched off the increased activity in that area. And looking at the actual clinical results, the treatment outcome, after 6 months of stimulation, a third of patients were completely better, and 60% of patients were responding. So they had a 50% or greater reduction in their depression ratings. At 3 years, half were completely better, 75 were responders. Again, by having the stimulator on, we're talking about 6 months or 3 years of continuous stimulation. Again, should we be doing this for all of our depressed patients? If I'm seeing someone coming in from a GP surgery with depression, obviously not. You're talking about a very intrusive procedure, but also you're talking about perhaps a highly selected group of extremely depressed patients who've been referred from centres across Canada. So it's probably a very specialised treatment that is applicable to only a handful of patients at any time. The other fast-acting drug I'd like to talk about is ketamine. And this is a drug that blocks a particular type of glutamate receptor called the NMDA receptor. And it was developed about 50 years ago as an anesthetic. And currently it's used for anesthesia in children. If you give it to adults, they'll quite frequently report hallucinations when they wake up. It's also used probably much more commonly as a treatment for pain. And just to give a sense of what the doses are like, for analgesia, the dose is around 1 milligram per kilogram. For anesthesia, it's around 10 milligrams per kilogram. So very different effects depending on what dose you give. And the studies I'm going to report in the next few slides are all using doses around half to 1 milligram per kilogram. So it's very much at a dose that's used for treating pain. And the first study I'm going to mention is from John Crystal's group at Yale. And John Crystal, throughout the 1990s, was looking at low-dose infusions of ketamine as a model psychosis. And again, one would wonder, why would you want to try and model psychosis? Isn't it bad enough having it in real life? Essentially, it's to try and look at some of the cognitive processes associated with it, and also as a screening tool for different drug treatments. And although it's not entirely clear from what they've published, I think one of the things they were doing towards the end of the 1990s was looking at different disorders where they expected no effect of ketamine. And one group that they tested it out was a group of 8 patients who had severe refractory depression. And I think when they went in, they thought, no one's going to show an effect. Now, the way these studies were designed was that they give patients either an infusion of saline over 40 minutes. So they pop a needle in, they have a syringe driver, and they whatever's in the syringe gets pumped in over 40 minutes, or ketamine, 0.5 milligram per kilogram. They'd have that on one occasion, then 2 weeks later they'd come back and have the other infusion. So it's what's called a crossover study in the same individuals. So when patients were given the placebo infusion, they had really no change in their depression ratings. This is looking at changes in a commonly used depression rating scale. The bigger the drop, the greater improvement in depression. So somewhat surprisingly, when they gave the infusion of ketamine, by 4 hours post-dose, suddenly depression ratings were improving. And they continued to improve out to 72 hours. And this was kind of a jaw-dropper. No one was expecting it. Mechanistically, no one had really thought, well, if we block glutamate receptors in the brain, it's going to have an antidepressant effect. So it stayed that way for the next 6 years. There was some work going on, and it wasn't until 2006 that Carlos Zarate at the National Institutes of Health repeated the study in 18 patients, same dose of ketamine, saline placebo, same basic design, and they wanted to see how long this effect might last for. So they, instead of stopping at 72 hours, they went out to a whole week. And they found basically the same results when they infused saline placebo into patients with major depression, with treatment-resistant major depression. They saw no real change in depression ratings. When they put ketamine in, by 4 hours, they were starting to see a substantial improvement in depression. It was sustained out to 72 hours, and then it started to wear off by a week. Again, very, very consistent results. And then finally, there have probably been another 4 or 5 studies that have confirmed these. Perhaps the most interesting results, though, are from Nancy Diaz-Granados, who also works with Zarate. And she looked at patients with bipolar depression. Bipolar depression is a bit of a tougher disorder to treat. 18 patients, refractory disorder, same basic design, 0.5 milligram per kilogram of ketamine infused over 40 minutes or saline placebo, and she saw that basically the same results. No real improvement in mood ratings on placebo. They actually saw a much faster response. By 40 minutes, they're starting to see an improvement in mood, and it's sustained out to 3 days, and by 7 days, it's starting to wear off. But still, even a little bit of response is evident in a couple of people by 2 weeks. The bottom graph here is showing the proportion of patients who are responders. So 50% reduction or more in depression ratings. By 40 minutes, almost 60% of people were reporting a substantial improvement. That was sustained out to 3 days, and then it starts to drop off after that time. There was one individual who'd been given saline placebo who showed a small sort of blip of a response at 7 days. But really, again, you've got a dramatic treatment response evident at that. So what's ketamine doing? Is it kind of like a chemical way of switching off Brodmann's area 25? We know that these are, glutamate is the major neurotransmitter here, and this is a drug that's blocking glutamate systems. It's possible that this could contribute to some of the effect that we're seeing, but certainly in terms of the rapidity of the response. But ketamine also has a 3-hour half-life. By say 9 hours, most of the drug is going to be out of the body. So, and we're seeing a much more durable response than that compared with the actual presence of drug in the body. And really what this has done is highlighted a whole lot of targets that until these experiments have been done, until these studies have been reported, just weren't on the radar of anyone who was looking at treatments for depression. I apologize for the complexity of this picture. I will try and talk you through it, but so what this is showing, what this cartoon is showing, is the space between two nerve cells, the synapse. We've got a presynaptic nerve here with vesicles, which is pumping out neurotransmitter. This is the blue blobs into the synaptic cleft. They're interacting with receptors. These are proteins that are specific to the neurotransmitter being released on the postsynaptic side. And then you're getting activation of signaling proteins, proteins that take the message that's coming from the receptor and do something with it, make new proteins, stimulate an electrical response. And what ketamine seems to be doing is, firstly, it's activating one of the key signaling proteins, a protein called mTOR. I know that this may sound like something out of a Transformers movie. It's called mammalian target of rapamycin, which is probably the worst name one could ever come up with when one is trying to name proteins. But mTOR is a little bit like the conductor in an orchestra. It has a key role in terms of telling other proteins to switch on or switch off. Another thing it does is it activates translation, makes new proteins. And one of the key proteins that we're going to talk about today is a protein called brain-derived neurotropic factor. So it starts pumping this out. It doesn't just pump out BDNF, though, that you see increased levels of a whole lot of other synaptic proteins. And ultimately, the effect is to increase synaptic plasticity, allow the nerve cell that's being stimulated in this way to reach out and connect with other nerve cells. And just picking up on the translation of BDNF, for those of you who aren't familiar with it, it's a neurotropin. There's a family of neurotropins, and BDNF is one of the most active of these. And it's involved with synaptogenesis, as I mentioned before. It also is involved with other more fundamental processes such as neurogenesis. It's active in the periphery with say, blood vessel development, with hepatocyte development. And it's a big protein. This is a molecular model of it. It exists as a dimer. So there are two proteins clamped together, two identical proteins clamped together, and each of these is 119 amino acids. So it's not that you can go to your health food store and say, I'd like some BDNF, please. You really need to make it inside you. You've got to make it inside of your nerve cells for it to be effective. You can't just sort of eat it or try and squirt it in. So how is BDNF linked to depression? Firstly, if you take out hippocampal BDNF, if you decrease levels of it, you can see depression-like behaviors in animal models. So, for example, you have animals that move around less. It disturbs their sleep. They get involved with hedonic behaviors. So drinking sucrose solutions, which rats or mice seem to enjoy, they do this less. If you put them in a forced swimming test, they will swim less and float more. If you then try and give them antidepressants to reverse some of these depression-like behaviors, in animals that have low levels of BDNF, the antidepressants don't seem to work. If you do the opposite and you increase levels of hippocampal BDNF, this produces antidepressant-like effects in animal models. And in a slide that I'll show in a little while, in patients who've been depressed when they've died, and we looked at tissue levels of BDNF post-mortem, these are reduced. Now, the reason the hippocampus may be relevant here is it's very much involved with cognitive processes, with memory processes. And it's interesting that one of the key neuropsychological findings in patients with major depression is that they show up as being quite cognitively impaired. You treat the depression and the cognition improves. The other thing that's even more interesting is that when you're depressed, your hippocampus gets much smaller. You see shrinkage of different brain areas. And given that BDNF is involved with synaptic development, with arborization, making dendrites, the fact that you get reduced BDNF levels may actually result in a reduced brain volume. And these are data from a group at Columbia in New York City looking at hippocampal volume in patients with depression compared with control. It's looking at the left and the right hippocampus. The solid symbols on the right-hand side of each of these graphs are the patients with depression. And what they've done is compared hippocampal volume with age and sex-matched controls, who are the open symbols on the other side. And you can see in almost all cases, the hippocampal volume is reduced compared with non-depressed controls. And you can see that the averages are also quite different. The same group then went on to look at hippocampal volume as a function of how long people had had not just depression, but untreated depression. And so the longer that you've got untreated depression, by the time you're getting out here, you've got 10 years, your hippocampus gets smaller and smaller and smaller. And there is some work now coming out of different groups showing that once you treat people, the hippocampal volume normalizes. This is a meta-analysis from a couple of years ago looking at serum BDNF. So initially we've been looking at brain BDNF. Serum BDNF, it's not quite clear where this comes from, but changes in levels do seem to be related to what's going on in brain BDNF. It's looking at levels of serum BDNF in patients with depression compared with controls. And what we've got are the results for the individual studies, and then the bottom diamond-shaped symbol is the pooled result. It's the average of all of these weighted by the size of the study. And essentially, people with depression have about 1 standard deviation less serum BDNF than controls do. So there's something that's switching off production of this protein or expression in the blood. If we give ketamine, this fast-acting antidepressant, what happens to BDNF levels in brain tissue? So this is one of the earlier, I say early, it came out in 2011. Autry et al. Looked at BDNF levels in hippocampus about 2 or 3 hours after giving ketamine, and you've got a 50% increase. So it's happening very, very quickly. This is a paper that came out a couple of weeks ago from a Chinese group showing that, again, in the same area, in hippocampus, you've got a dose response. The more ketamine you're giving, 5, 10, or 15 milligrams per kilogram, you're seeing a greater production of protein in those brain areas. What effect does increasing BDNF actually have to neuronal structure? This is from, again, a fairly recent paper looking at spine density. So these outbranchings you've got, I've marked some of them with yellow arrows, but you can see you've got a lot more spine density in prefrontal cortex at 24 hours post-ketamine. We've also looked at the effect of other treatments, more traditional treatments on serum BDNF levels. This comes from a German group a couple of years ago. And what this group did is take about 40 patients, and all of them were put on sertraline, but the 20 or so patients who are highlighted by the green symbols and the green line also got a day of sleep deprivation as well. The first thing to notice is that their serum BDNF levels were, on average, much lower than those seen in a control population. So the shaded area here is what we think of as being a normal range of values for serum BDNF. All the patients with depression, before they'd started treatment, had levels that were much, much lower than that. In the people who got sleep deprivation, within 24 hours, there's about a 25% increase in their serum BDNF levels. So that sleep deprivation is having an abrupt improvement in mood, and it's also doing something to their serum BDNF. The people who just got sertraline alone, no sleep deprivation, over the space of 6 weeks, they had a gradual increase in their serum BDNF levels. They gradually got an improvement in their mood ratings. But it looks like some of what the sleep deprivation may be doing is not only giving you a jump start in terms of your antidepressant effect, but we may be seeing mechanistically what it's doing by pumping up levels of BDNF. Looking at some of the human post-mortem data, if we look at patients who've had depression, who've died, and those on antidepressants versus those who aren't on antidepressants, we see that those on antidepressants have higher levels of BDNF in hippocampal tissue. These are the dark bars, compared with those who are depressed and weren't on antidepressants at time of death. And this is what we're looking at here are a number of different areas in the hippocampus. And the effect of the antidepressant is consistent in all of those areas. The meta-analysis I mentioned a few slides ago, looking at serum BDNF levels in patients with depression, being lower in depression versus controls. When you put those patients on an antidepressant, the net result is that you increase serum BDNF levels. You can see there's much more heterogeneity based on the individual studies, but the pooled results suggest about a half standard deviation increase in serum BDNF levels once people have been on an antidepressant. What does ECT do? This is again a fairly recent study showing that in 20 or so individuals who had ECT, the ones who responded to treatment showed an increase in serum BDNF. The ones who didn't respond to treatment really didn't show any change. So it's possible that it's also not just a marker of giving an antidepressant, but in functional terms, if you show a response, you're going to get a bigger increase in levels. So, in summary, we actually do right now have some treatments that have the potential to be quite rapid in onset in how they treat depression. Now, none of them are approved by MedSafe. And again, I can't see that MedSafe is necessarily going to take a role in mandating that people have sleep deprivation for their depression. But again, the issue here is not necessarily are these treatments going to be available for depression. That really what I think they're highlighting is a mechanism. And the mechanism is that if you can increase production of BDNF in the right brain regions, potentially it's a final common pathway for antidepressants. We have psychotherapy, we have 13 different drug classes, ECT, mood stabilizers, we have ketamine, we have anticholinergics. It's possible that all of them at some point are increasing BDNF levels, and that's what you have to do to improve mood. And the main differences between them are going to be in how quickly they can do this. So that the differences in speed of onset of antidepressant effects may simply reflect how quickly or how slowly you do this. And ultimately, it may not be BDNF itself that's important, but that you're creating connections between nerve cells. So again, in cartoon form, we have a happy euthymic individual who's got nice, healthy-looking nerve cells with lots and lots of dendrites, reflecting an adequate production of BDNF. We have a depressed person. We see shrinkage in brain areas, and perhaps that's reflecting a reduction in BDNF levels, and it could reflect stress. It could be due to some sort of genetic influence. And when we're treating people, and again, most of what we do is with medications. Some patients get ECT. What we may be doing is ultimately creating higher levels of BDNF that allows normal levels of synaptogenesis. And what I'm trying to highlight here is that the rate at which you can do this may be the important thing. So only 2 more slides to go. So looking at this as a drug development problem, in between the receptor and proteins like mTOR, you have a number of different steps in that signaling pathway, which may potentially be druggable. You may be able to create agents that can ultimately wind up in stimulating high levels of BDNFs. And how could these be used clinically? Now, the obvious thing is something like treatment-resistant depression. That seems to be what all the clinical trials have been carried out. And one issue that's been raised by a number of commentators has been, well, you've got a drug that works great, something like ketamine, but it only lasts 3 to 7 days. How are you going to use this in practice? And I guess the short answer is I don't know. The longer answer is we may have some clues. And these are data that have been published recently by my colleague, Dr. Zanacotti, looking at a patient we had enrolled in a clinical trial using ketamine in depression in patients with terminal cancer. This was a lady who'd been depressed for 18 years, had widely disseminated ovarian cancer, and showed a beautiful response to an initial dose of ketamine. And said that she'd like to continue getting it. So over the space of a couple of months, we'd wait for her depression to come back, and every time she'd show the same sort of response. So this is a commonly used depression rating scale. The higher the value, the more depressed you are. After about 8 weeks, she said, I'm sick of getting depressed again. You know, could you just give me a treatment once a week? And we continued the treatment for the next 8 months or so. And although it seems as though there are peaks and troughs occurring here, they're way below the level needed to be clinically depressed and probably reflect things like perhaps not having a great appetite or not sleeping terribly well, but no real return of her depression. At the end of that time, her request was, you know, I've been well for 8 months, can we stop the treatment? And so we stopped the treatment at that point, and her depression never returned. So the question is, if we treated someone with antidepressants for 4 weeks and then stopped, my guess is most patients would relapse. It's possible that we're seeing the same thing here, that one of the theories as to why antidepressants work is that once you've lifted the mood up, you're waiting for the rest of that depressive cycle to pass. And typically it takes about 6 months or so to reduce the risk of the same depressive cycle recurring. It's possible that what we did here was abort the episode of depression, kept the depression away for long enough, and that we got sustained improvement in mood once we stopped the treatment. The other possible clinical uses is actually to come back full circle to one of the first slides I showed you, which is analogous to how I think a lot of anxiety is treated these days, which is to see BDNF enhancing treatments as a possible induction treatment, that we get someone who's severely depressed, we use something that works quickly and can be used short term to get people out of their depression, while at the same time we initiate conventional antidepressants. And what we do then is simply go into a much more conventional style of treating depression. So thank you very much, and I'm happy to answer any questions. It's possible that one of the mechanisms that may be happening is by pushing up levels of BDNF. However it's working, though, it seems to be not terribly effective based on the clinical data that suggests if you, it only seems to have a relatively brief effect. And in practical terms, you can't keep people awake for more than 1 or 2 nights without the risk of them either being very cranky or producing, paranoia or a psychosis.
Can I just say that there is a roving mic coming around so that everyone can hear the question?
Okay,
here we go, just here.
Lady in the maroon.
How much do they cost?
Sleep deprivation?
How much do the weekly treatments cost?
This is the ketamine injection. The ampules are about $50 each. And then whatever the cost of administering it or infusing it. But it's not wildly expensive. If you're looking at patients who are otherwise hospitalized or functionally very impaired, the cost of hospitalization runs at about $1,000 a day. The cost of someone being unable to work might translate into, say, being on sickness benefits or other things. In purely pharmacoeconomic terms, the costs are not that high. Lady in...
Okay, I've got 2 questions. That's sneaky. First of all, is ketamine being used, has it been approved and used in clinical practice anywhere?
No, it's not approved anywhere.
The other thing is I've heard that some psychiatrists with people with severe depression are starting with quite a high dose rather than going low and slow. And I wondered if that was because to avoid that whole thing, if you put somebody on 20 milligrams and it doesn't do much and then you have to put it up to 40 milligrams, or if if it acts faster in a higher dose.
Yeah. Typically, by starting people on high doses of antidepressant, you get terrific tolerability problems. And especially if someone's got anxiety, as part of their depressive picture, you may worsen that. So generally, I try and say to patients that we're going to just ramp things up gradually. I'm not sure that anyone's shown that starting at a higher dose gives you a faster antidepressant response. And then finally, for most antidepressants that we have in New Zealand, most of them actually have quite flat dose response curves. So 10 milligrams of fluoxetine doesn't do that much more in terms of an overall treatment response than, say, 40 milligrams. So there may be some people who don't respond to 10 but will respond to 40. But in population terms, you can't identify who those individuals are. Lady in green.
I'd like to know what are the side effects of all this antipsychotic treatment, and are the treatment a lifelong treatment, or it can be stopped if the patient is cured?
So the side effects of the antipsychotics really depend which ones you're using. Some drugs such as olanzapine or quetiapine can be quite sedating. Others can look like amisulpride can push up plasma prolactin levels, and you can see galactorrhea, you can see sexual performance problems in males. Generally, the doses that are being used for antipsychotic, for antidepressant effects tend to be a little bit lower than those that might be used in primary psychotic illnesses such as schizophrenia. And sorry, your second question? So the question was, do patients need to be on treatment for lifetime? That's quite a nuanced question. If I was seeing someone who'd had a first or a second episode of depression, which wasn't particularly severe, my recommendation would be treat until they get completely better and then add 6 months onto that. And then you could titrate down and stop the antidepressant. If somebody, once you've had an episode of depression, your risk of a second episode becomes 50%. Once you've had 2 episodes, your risk is 90%. So it's not if it's going to happen, when it's going to happen. If somebody is having very frequent depression, say 3 and 5 years, I'd probably look at putting them on something long term. If they'd had a particularly severe depression, say with psychotic symptoms, a depression that took forever to respond, you may want to work very conservatively and leave them on something long term. But typically for someone who's had a first or second episode, I'd look at treatment for 6 months and then to stop it. Gentlemen, and then this lady in the black cardigan behind. Oh.
I'm just wondering whether exercise increases the BDNF, whatever it is.
Serum BDNF. That's a good question. I don't know the answer to that. Do you have a researcher's soul in your body? Because this would actually be a very easy thing to do. So firstly, I don't know. In terms of depression and exercise, I encourage my patients to stay fit, to lose weight, to get out and exercise. Every time people have done a clinical trial to show increasing exercise effect on mood, it's been very difficult in a clinical trial situation to show that it actually works. But in terms of basically, being healthy, being engaging in socialized activity, having a routine in life, I don't see there's anything wrong with it. It's just very difficult to quantify the benefits. If you could show that it increased serum BDNF levels, perfect. Okay.
How is deep brain stimulation administered? Okay.
Firstly, you need to find a good neurosurgeon with a steady hand. It involves putting a burr hole into the skull. So opening up a flap of skin, putting a burr hole in, and then using a stereotaxic frame to insert a very fine wire. So we're talking about something that's about the thickness of a broom bristle, which would then be placed in the brain area. The wire itself is then run under the skin, and often there's a stimulator that can be put in the chest cavity, can be put in the abdomen, and once the wire is in place, the wire itself will have 10 or 12 electrodes, and then different combinations of the electrodes can be stimulated to achieve a desired effect. So if you're using it for, say, treating Parkinson's disease, you'll be looking for, say, changes in motor symptoms. In depression, essentially you've got a patient who's awake on the table, and the results are pretty dramatic. Suddenly, hey, I'm not depressed anymore. It's that kind of result. Don't try this at home. You really need you really need to have all the right equipment and an experienced surgeon to help you. Gentleman in white.
So children are bad witnesses often. I'm wondering how we detect if ketamine was causing hallucinations in children. And if I can sneak in another question, what physical side effects does ketamine have in adults, and what precautions would you need to avoid somebody breaking the blind in a crossover trial?
Ooh, that's about 4 or 5 questions. Okay. Why children don't have hallucinations when they wake up from ketamine is a fascinating question, and it's possibly due to a number of different processes going on. So when you're about 12 or so, you have probably the greatest number of connections between both within cortical areas and across cortical areas. And most of adolescence and early adulthood involves a pruning process, losing a lot of those connections. It's possible that pruning process is why many of the major illnesses, bipolar disorder, schizophrenia, perhaps some of the mood disorders, start to appear at that time, that you're seeing a disorder that's reflecting abnormal or inappropriate pruning. It's possible that the increased connectivity that you see in children's brains is maybe preventing some of the side effects that we're seeing with ketamine, in particular the hallucinatory part that's associated with people coming out of anesthesia. The main side effects in the antidepressant trials that have been published, people will sometimes be very sedated, will report a sense of dissociation, the sense that my arms or legs aren't connected to me. Typically it peaks at about 40 minutes in the infusion studies and then disappears. People will feel a little bit woozy. It's difficult to think, it's difficult to find words to express things. In one of the bipolar patients in the Diaz Granados study, developed a brief period of mania, felt very high and very buzzy for a short period of time, and then it went away. Breaking the blind and double blind studies is tough. Generally, if you're using medications, you can open up the capsule and see what's inside of there. Is there a Tic Tac or is there a real pill? Generally, if I'm running studies like that, I try and have directly observed dosing rather than giving people a big pile of capsules to take away. But achieving double blinding in studies is critical to actually, the whole scientific process. If I've forgotten a couple of your questions, I apologise. Next. Gentlemen. So.
Could you tell us if this BDNF is always associated with all depressions, lowering of the BDNF? And I guess whether or not that's the case, do we know what causes an onset in lowered BDNF?
Those are great questions, and I think if your research soul is still active, these are the things that could keep you busy for the next 20 years or so. I think on the second or third slide where I said there were probably many types of depression, there probably are depressions that are not associated with altered BDNF activity. And it's possible that it's difficult to know how they might be detectable. For example, do they have particular patterns of symptoms? Is it something that we could pick up with a blood test? Will they respond to different treatments? So look, I think the jury's still out on those. I'm hoping that the last sort of 4 or 5 years, especially since the Zarate article came out, there's been a huge flood of work in this area, and a lot of it's really still emerging. And as someone who's sort of very interested in developments there, it's almost impossible to sort of keep up with what's getting published at the moment.
I have a question on bipolar disorder, please. Is it typical that while drugs can be very effective, like lithium, in dealing with the mania of bipolar, they're not at all effective in dealing with the depression?
I'm not sure if I totally agree with your statement there. I think if the bipolar mania in some individuals can also be tough to treat. Some bipolar illness, especially if one has had a large number of cycles, may become refractory, especially to lithium. There's work from the Boston group, which has looked at effectiveness of treatments in both mood elevation and depression. Once you've had about 8 cycles, lithium becomes much less likely to work, but drugs like valproate do seem to sort of maintain some effectiveness. Having said that, bipolar depression, if it doesn't respond easily to treatment, can be extremely tough to treat. There's a tautology there. If it doesn't respond to treatment, then it's difficult to treat. But I see a lot of refractory depression, and probably, a good third of my patients have bipolar 2 disorder. Often the strategies that are needed don't involve antidepressants. I'm always concerned about the risk of either pushing people into mania or pushing people into rapid cycling, which is really tough to treat. And often the approach may need things like combinations of mood stabilizers. There's some really interesting work coming out of Michael Burke's group in Australia, looking at N-acetylcysteine, that again, it's a drug that increases levels of glutathione throughout the body, and may suggest that one of the approaches that's important is to enhance cellular metabolic activity. With glutathione, we're looking at mitochondrial function in cells. So I think there's sort of fairly active work trying to understand different approaches. And what you're highlighting there with bipolar depression may be that it's a particularly tough subgroup of depressions, and may need quite different approaches from some of the things I'm talking about here. It'd be nice to show BDNFs involved with it as well, but again, the jury's still out on that.
Thank you very much. It's been such an insightful sharing of information you have given us today. You've obviously generated a lot of questions. Maybe if there are 1 or 2 questions still remaining,
Sure.
people could talk to you
Sure. Look,
outside the lecture theatre.
I'm very happy to talk. I've got to duck off at 1:30, but I'm happy to chat after this meeting.
Thank you very much.
much.
Let's join.